Right, our next speaker is Dr. Catherine Coleman from Victoria. Dr. Coleman is a paediatric oncology fellow at the Royal Children's Hospital in Melbourne with a particular interest in paediatric leukemia and stem cell transplantation. As a Mark Track scholar, Dr. Coleman has commenced her PhD this year at the Walter and Eliza Hall Institute of Medical Research, investigating chemotherapy resistance in paediatric acute lymphoblastic leukemia, and is working in novel drug discovery. Her presentation is titled BH3 Mimetics, Highly Effective in Relapsed or Refractory Pediatric Acute Leukemia, Real-World Experience from the largest Australian centre. So I'm just going to do your right.
So every year in Australia, there are 280 children diagnosed with leukemia. And while we have well-evidenced frontline therapies, unfortunately, 12% of children with acute lymphoblastic leukemia or ALL relapse. And for kids that relapse, the long-term survival ranges from 50% of those with B-ALL to only 20% of infants. For children with acute myeloid leukemia, AML, the outcomes are even worse, with 40% of kids relapsing and 1 in 3 of those surviving long-term. Most relapses need a bone marrow transplant as the only chance of cure. But we know that the lower your leukemia burden prior to transplant, the better your outcomes. But for many children, they are unable to achieve the required remission to progress to their life-saving transplant. Often this is due to chemotherapy resistance. So one solution is to target this with venetoclax. This is a novel chemotherapy agent developed in adult leukemia that targets BCL2, one of the guardians of cell survival. And this allows the leukemia cell to die via the normal apoptotic pathway. There are some small phase 1 trials of venetoclax in kids, but very few talk about transplant. And we know that clinical trials don't always reflect the wider population due to strict inclusion and exclusion criteria. So we wanted to know, what is the real-world experience of venetoclax? We did a retrospective review of 18 children who were treated with venetoclax as a bridge to transplant at our centre. At a balance of ages and genders, and half of children were treated for AML, just over a quarter for ALL, and the remaining patients for treatment-related leukemia after having already survived a previous childhood cancer. Children had a wide range of leukemia burdens, including up to 90% of their bone marrow being leukemia cells, and half of the patients, or the ones in red, had what we call frank disease, so more than 5% of their marrow was leukemia, with the remaining having measurable residual disease, or MRD disease, less than 5%. And patients were heavily pre-treated, with a median of 2, but a range of up to 5 prior lines of chemotherapy, including 4 previous transplants and 9 previous immunotherapy. And despite this, we had excellent outcomes. We had 16 of the 18 children obtaining a complete remission, of which 2/3 were MRD negative, so no disease even down to a molecular level. 3/4 of children were able to progress directly to their bone marrow transplant, with 1 child declining a transplant and another 2 needing further chemotherapy prior to their transplant. Only 1 of the 18 kids was not able to progress to his transplant. And this occurred at a really rapid time frame, at a median of only 32 days from the first dose, allowing kids to move to transplant at a median of 2.5 months. This Kaplan-Meier curve shows our 2-year overall survival was 78%, with event-free survival of 42%. Even out to 4 years, our overall survival was more than 50%, which is way better than that graph I showed you on slide 1. And this was a really well-tolerated therapy. No child had to stop venetoclax due to side effects, and the median quality of life score was 80 out of 100. This is quite a complicated graph, but it basically shows the 18 kids down the y-axis and the time following their first dose of venetoclax in months on the x-axis. Where their bar is red, they have frank disease, and where it turns to blue, they're in remission. Triangles are their bone marrow tests, with red being MRD positive and blue when it changes to MRD negative, so no detectable disease. You can see kids have a short duration of venetoclax in the dots before moving to their transplant in the green donut, and then many go on to have a long period of remission. In fact, 3 of the 4 kids with acute lymphoblastic leukemia are alive, and 1 up to nearly 5 years post-venetoclax. 7 of the 10 patients with AML are alive. All of those 7 are in remission. And even for the children with a secondary leukemia, which classically has a really poor prognosis, 3 of the 4 children are still alive, 2 in remission, and 1 unfortunately really recently relapsed and is undergoing further therapy. So this is exciting progress in what is normally a really deadly disease. This is the largest paediatric single centre experience of venetoclax, showing that it's highly effective in salvaging paediatric leukemia, especially those that are chemotherapy refractory. A really high remission rate of 89%, of which 2/3 were MRD negative, and patients were bridged to a transplant at a rapid timeframe of 2.5 months. This meant it was useful in facilitating long-term remission. And moreover, this is an oral chemotherapy drug that people can have at home and is well tolerated. Further research is always needed to enhance our understanding of therapeutic response, to predict which kids will and won't respond, to optimize rational therapeutic combinations moving forward. Thank you.
Questions?
Yes.
Thank you, very interesting. I was just interested to know, you had to do the venetoclax and then your plan was to go to BMT.
Yes.
Could you conceptualize where you wouldn't need to go to the BMT if you had minimal residual disease or less?
Yeah, so that's a good question. We know that for children with relapsed AML, that you have a much better chance of cure with a transplant than without, even if you have MRD negative disease. And that's just because we know that relapsed AML is a very aggressive disease, and there's really good long-term longitudinal studies, including some randomized control trials in pediatrics. So unfortunately, even the kids that achieve remission do still need to go to the transplant, because otherwise it will come back.
So that next question was, do you sustain them on the venetoclax or they stopped?
No, they stop actually. So if I quickly flip back to the graph, you can see that they're only on venetoclax for a short period of time, the dotted bars. So the median duration of therapy was that 32-day mark. And then they actually stop venetoclax, have their transplant, and then the transplant gives them what we call graft versus leukemia effect, and that maintains their remission long term.
Thank you.
Questions?
Yes.
This is a cohort study. Did you manage to have like a control group at all?
We didn't, unfortunately. I think that would be a really useful idea, to go back and have a look at the kids that say weren't given venetoclax. But I guess the problem is, if you can't achieve the depth of remission, you can't go to transplant, because if you go into transplant with leukemia, then the leukemia will grow faster than the grafted bone marrow will. So if you enter transplant with disease, you'll die of disease before your transplant kicks in. So I think that's the biggest limitation, is that it's hard to have a really good control group. Perhaps you could look at other things that have bridged patients to transplant. It's useful. I just advance to the next slide.
Thank you, Catherine.
The next presentation today is by Dr. Joanne Nixon from the Northern Territory. Dr. Nixon is an infectious diseases physician at the Royal Darwin Hospital and has a broad generalist background and a particular interest in Aboriginal health, striving to improve access to care and health outcomes for Indigenous communities. Outside of medicine, she enjoys spending time in the great outdoors here in Northern Australia, exploring the Northern Territory with her young children and embracing the natural beauty that surrounds her. Today, Dr. Nixon will be presenting on VitaFoot, a double-blind randomized controlled pilot trial of micronutrient supplementation in people with non-healing diabetes-related foot ulcers. Thank you so very much, Dr. Nixon.
So over the past few years, I've had the absolute pleasure of working with Professor Lauren Manning to explore new ways to improve healing in diabetic foot ulcers. Despite current treatments, healing rates remain extremely poor. Alarmingly, 1 Australian loses a limb every 2 hours due to a diabetic ulcer. There is an urgent need to evaluate new approaches to improve diabetic foot ulcer healing. So why the focus on nutrition? The literature has shown that there are high rates of micronutrient deficiencies in the diabetic population, and nutrients, as we know, are essential for tissue healing. Small studies suggest benefits of vitamin C and zinc supplementation for wound healing, but larger trials are lacking. So we've conducted a pilot trial testing whether micronutrient supplements can become a safe, effective, and low-cost intervention for diabetic foot ulcers. So today, I hypothesise that 28 days of combination vitamin C, vitamin A, and zinc supplements result in greater reduction in wound area at 12 weeks compared to placebo. So we conducted a prospective, randomised, double-blind, placebo-controlled pilot trial. Participants were randomly allocated to either intervention or placebo arm. Intervention group contained vitamin C, 1,000 milligrams, vitamin A, 750 micrograms, and zinc, 25 milligrams in 3 capsules. Placebo capsules were identical in appearance. Patients continued with standard care. Detailed assessment of the index ulcer and blood tests were performed at baseline, 4-week and 12-week intervals. Primary outcome was a reduction in ulcer area from baseline to 12 weeks. So let's look at the results. So we screened 546 patients and enrolled 99. 49 were allocated to the micronutrient supplementation group. Patient characteristics, as you can see, were fairly similar between the two groups. Vitamin C and zinc deficiencies were high in groups. The median wound area at baseline was 0.95 centimetres squared in the placebo group, and 0.9 centimetres squared in the intervention group. Participants in the intervention group had a chronic diabetic foot ulcer present for greater than 12 months, and this will become relevant later on in the discussion. So was our hypothesis proven? When looking at our primary outcome, there was no difference in the decrease in wound area at 12 weeks, with a 75% reduction in placebo compared to a 65% reduction in the intervention group, p-value of 0.42. There's no difference in complete ulcer healing at 12 weeks. But interestingly, at 4 weeks, participants in the intervention group had complete wound healing, 1 patient compared to 7 patients with a p-value of 0.02. In our bivariable analysis, patient demographic factors were not significantly associated with wound healing. Larger baseline diabetic foot ulcer area was significantly less likely to completely heal 12 weeks, with a p-value of 0.0006. So currently our data does not show that vitamin supplementation improves wound healing at 12 weeks compared to placebo. However, more patients taking vitamins had healed ulcers at 4 weeks, and the supplements were well tolerated with no increase in side effects. We made note of a few confounding factors. Firstly, many chronic wounds were assigned to the vitamin group. This may have impacted healing trajectory, as chronic ulcers can be impacted by pressure, vascular, infective, or hyperglycemic factors. Secondly, vitamin deficiency results were released at 4 weeks, leading to crossover, as patients sought supplementation before the 12-week mark. Finally, 12 weeks as an endpoint may have been too short. Some evidence suggests ulcers take 17 weeks or more to heal. Despite high rates of micronutrient deficiency, current data does not support routine testing or supplementation. Finding of complete wound healing at 4 weeks with vitamin supplementation warrants further exploration. I envisage a multi-site RCT with a larger sample size and minimal crossover to further explore the efficacy of micronutrient supplementation in this vulnerable population. Thank you.
Any questions from the room, please?
Thank you. It's very interesting. I was just wondering, what was the rationale between in terms of choosing those 3 particular micronutrients?
Yeah, so I suppose there were a few reasons. First is what we know about of those nutrients for tissue repair. So that was performed through an extensive literature review. It's proven previously in literature that vitamin C, vitamin A, and zinc are required for healing and tissue repair. The second reason would be how common deficiencies in those vitamins are in this population. Multitude of factors causing that. Host factors would be patient's preference in diet, confounding issues such as diabetic gastroparesis, food intolerances. Then there would be social factors, so finances, current cost of living, access, living and working in Darwin, access to fresh fruit and veggies is tricky. So yeah, those would be the main reasons.
Do you have any, I guess, data to inform at histories or what they're actually eating?
Yeah, we did. We collected data using an interview pre and post the study and that study. So stay tuned.
Did you ever considered, I don't know, to add vitamin D or?
Wasn't, and we would need to look into the benefit of vitamin D in tissue healing and the role before we would consider supplementing as well. Yeah.
A question from the GP as well. So lots of wounds we've noticed in general practice do heal quicker. Your study does seem to suggest that the wounds do in fact heal quicker, although the endpoint isn't different. And I guess the question I have, apart from the 50 other questions I have on this one, it's so interesting, is this. Do you think that might be protective against infection, having a wound that's closed earlier?
Oh, absolutely. I mean, as an infectious diseases physician, skin is, the main protection we have against the environment. So yes, definitely, if you're quicker, you're less likely to get an infection.
Most positive, negative finding I've been.